I'm Umair, PGY3. I'm presenting a health stroke. So, am I audible? Can everyone at Wesley Chapel hear me? Yes, I think it's audible? Yes. Okay. So, oh, yes. So we'll go over some definition, etiologies, definition of stroke, subsequent management after acute management and conclusions. So, is a stroke. Anyone want to comment on it?
Yeah. A stroke is a rapid onset of neurological dysfunction caused by lesion to cerebral blood flow. A disruption of cerebral blood flow.
Yes, so that's ischemic stroke. Yeah, but it's a definition. So stroke is a neuronal infarction. It occurs due to uh, decreased blood supply to the brain. It could be just a minimal blood supply, complete occlusion, and we know that there is a type of hemorrhagic stroke. So it could occur because of that too, and it results in sudden loss of focal brain function. So there are two main types of stroke: ischemic stroke, hemorrhagic stroke. Ischemic stroke is more common, about 80%, and this is the one that is related to either blood supply or complete occlusion of blood supply to the brain. And hemorrhagic stroke, that's related to hemorrhage. So some of the causes of ischemic stroke are large artery atherosclerosis, embolism, small vessel occlusion, and some undetermined unusual causes and idiopathic stroke. So we'll go over each of these. So first one is stroke due to small vessel disease. It results in subcortical or lacunar strokes. Most common cause of lacunar strokes is hypertension. So chronic hypertension causes hyperplasia of tunica media of small blood vessels of the brain. Over time, it results in lumen narrowing and occlusion and results in stroke. Another common cause is atherosclerosis. Chronic atherosclerosis or sudden plaque rupture leading to thrombus formation and occlusion can also cause lacunar strokes. So these lacunar strokes affect deep areas of the brain, ganglia, thalamus, internal capsule. They can be asymptomatic because they involve very small penetrating branches and can lead to cognitive decline over time, or they can also cause just pure motor symptoms, pure sensory symptoms, or both sensory motor symptoms. So why we call these lacunar strokes is, so lacuna means cavity. So it's hard to detect these strokes on non-contrast CT scan if it's acute. But from over time, these strokes leave a cavity in the brain. That's what we see as well. And that cavity is called lacunar. So that's why we call these lacunar strokes. So here is a non-contrast CT scan of the head axial view. So any radiology PY resident wants to comment on it if they see any abnormality here. So yeah, very small, like you can see here, there. So here, these are small lacunar parts. So here, this is package. So to see, so this is the chronic subacute or chronic many parts, because we cannot detect these on acute if it's acute.
How long time does it usually take to get up to there?
I'm not sure about specific time, but at least I think so, a few days to weeks probably.
What was the question?
So he was asking that lacunar strokes causes a cavity. That's why we call these lacunar or subcortical strokes. How long does that take to form that cavity? So I don't think so that there is any specific time interval. I did not.
So
think
it won't
about it.
show up on an acute CT, but if you wait 48 to 72 hours later
Guaranteed.
and do follow-up MRIs, then you'll see them.
Yes.
Or if they're old. So you get a CT scan on acute, but it shows lacunar, that means it's an old stroke from before.
So next one is large vessel disease. So some of the large vessels of the brain are anterior cerebral artery, middle cerebral artery, posterior cerebral artery, and basilar artery. So and if stroke happens due to any of these arteries, most of the time patients are candidate for fibrinolysis or mechanical thrombectomy. I will go over most of these in the next slides. So here is another non-contrast axial CT scan. And anyone wants to read this? Right.
There's a large process in the left middle cerebral artery. It's an MCSI.
Yes. So here is it. So we can see that hypotensity in the temporoparietal region, most commonly due to middle cerebral artery stroke. Yeah. So then there are some non-common causes or non-atherosclerotic causes of stroke. It could occur due to arterial dissection. Below is the image shows that first dissection happens, then over time there is just thrombus formation, and over time it just causes complete occlusion, resulting in stroke. Another uncommon cause is fibromuscular dysplasia. It's also a non-atherosclerotic disorder that can cause narrowing of the blood vessel, or it can also cause aneurysm formation leading to stroke. Vasculitis is a common cause. Moyamoya disease is also an uncommon cause. So what is Moyamoya disease? It's so in Moyamoya disease of the blood vessels of the brain, the large vessel ACA, the cerebral artery, posterior cerebral artery, over time there is narrowing of these arteries, and it results in formation of collaterals. Those collaterals gives a smoky appearance on angiography, and that is called moya moya. That is a Japanese word that means hazy. It's also a very uncommon cause, and sickle cell arteriopathy can also cause stroke. So now we can go to embolic strokes. Cardioembolic strokes are common, and another cause of embolic stroke are arterioembolic strokes. So a common cause of a cardioembolic stroke is atrial fibrillation. So all of these patients who are admitted for stroke, they should be on continuous doubling history. Sometimes we know that they have history of atrial fibrillation. Sometimes we don't know, but it's a part of stroke workup that we need EKG, and they should be on continuous doubling history. Fatal foramen ovale can also cause stroke. I will go over PFO next slides. Some other uncommon causes of embolic stroke are left ventricular aneurysm or hypokinesis if someone has mechanical heart valves or endocarditis. Arterial embolic strokes can occur due to carotid artery stenosis or dissection. I will go over carotid artery stenosis because we see a lot of patients here in carotid artery, with carotid artery stenosis because it's a part carotid ultrasound or CT angiography is a part of stroke workup, but it is also a part of CABG workup too. So most of these patients, even if they have asymptomatic carotid artery stenosis and it's significant before doing CABG, we need to treat this too. So atherosclerosis is the common cause. Some imaging modalities that we commonly use are carotid duplex ultrasound and CT angiography. Digital subtraction angiography is done by interventional radiology. So if someone has carotid artery stenosis, management, they all need medical management, even if we focus on treatment too. Medical management, lifestyle modification, that includes they have hypertension, they have diabetes, if they are smoker, that includes smoking, and then aspirin and statin. So two common revascularization strategies are carotid endarterectomy, that we surgically remove the plaque, or carotid artery stenting. And carotid endarterectomy is a preferred treatment if someone can tolerate surgery. They don't have any previous history of endarterectomy on the same side. But if patient is a poor surgical candidate and they develop restenosis after carotid endarterectomy on the same side, then we can do carotid artery stenting too. So this is angiograph image. So we can see that there is blocked internal carotid artery. After that, in the second image, stent was placed, and there is a good flow. And the third image just shows post stent placement, good flow, and the block. So management of carotid, surgical management of carotid artery stenosis depends on whether the patient is symptomatic and what is the level of severity. So if stenosis is less than 50%, most of the time they are asymptomatic and we don't need to go for revascularization. Medical management is enough. But if the stenosis is 50 to 69%, that is moderate stenosis, and if someone is asymptomatic, most of these patients also don't need any revascularization. But if they, but we can consider revascularization if there is significant benefit, like I mentioned that if these patients are going for cabbage and they have 70% stenosis, so they may benefit from it. So, and if it's symptomatic, whether it's moderate or severe stenosis, then we need to consider them for surgical revascularization if there is no contraindication for that. Any questions so far?
Can you please repeat if they're going at cabbage? Consider?
So yes, so
Repeat the question.
so he's asking that why will we consider revascularization of carotid artery stenosis if they are going for cabbage? So if they are going, so cabbage is a big surgery, and we know it's a bypass. So if during surgery there will be decreased blood supply to the brain, and if they have severe stenosis there, it can cause ischemic stroke. So before going for a big surgery, they would want us to manage this one so that we decrease the chances of stroke. So, and we see, I have seen at least 6, 7 patients here whom we were following, and they had carotid endarterectomy a couple of days or a week before they had cabbage here in the hospital. So, PFO is another cause of embolic stroke. Just a little bit about pathophysiology, that during fetal development, there is failed fusion of septum primum and septum secundum, and it results in patent foraminal ovale. And if someone has PFO, then venous thrombus can embolize into the systemic circulation and can result in stroke. So here's the diagram. You can see that clot enters from superior vena cava or inferior vena cava into right atrium, from PFO to right left atrium, and then left ventricle and through aorta into systemic circulation, and it can result in stroke. So all of these patients need PFO closure, and we need to determine whether these patients need anticoagulation or discharge on antiplatelet therapy. So I saw a patient on the floor about a year ago. She was 57-year-old, presented with sudden onset right-sided weakness. So she had small infarct and MRI. As a part of a short workup, we did echo, and she was found to have PFO. So just to complete the workup, we did ultrasound Lower Extremity Doppler, and she was found to have right-sided DVT. It was non-inclusive, about 70%, and she was asymptomatic. But cardiology was following, PFO was closed during the same hospitalization, and neurology was also following, and we started her on anticoagulation because most likely that was the cause. She only had hypertension, no other past medical history, and hypertension was also well controlled. But I saw a few patients during my neurology rotation that they had PFO, but anticoagulation was not started. So I saw a couple of patients, 70, 75 years old, that history of hypertension, diabetes, smoking. In that case, we know that atherosclerosis is probably the most likely cause of stroke and not the PFO, and they did not have DVT2. So although PFO closure was still recommended to reduce the risk of future stroke, but they were started on antithrombotic therapy with aspirin and Plavix and not anticoagulation, because we know that the most likely cause of stroke was atherosclerosis and not the PFO. So hemorrhagic stroke is relatively less common. About 20% of the patients with stroke present with hemorrhagic stroke. So some of the common causes are uncontrolled hypertension, polysubstance abuse, cerebral aneurysms, if someone is on oral anticoagulation or AV malformations. So this is a non-contrast CT scan of the head, and we can see that there is a large intracerebral hemorrhage on the right side. So after stroke, we see a lot of transient ischemic attack patients or TIA. Anyone wants to comment on it? What is a TIA?
It is a transient loss of neurological function that lasts less than 24 hours.
Yes. So yes, it's a good definition, but not complete. So TIA is a transient loss of focal deficit that mostly recovers within 24 hours. But the main thing here is that there should be no radiographic evidence of infarction. Suppose a patient comes with sudden onset right-sided weakness, left-sided weakness, or any neurologic dysfunction, and their symptoms resolve within 2 hours. We do MRI, CT scan, everything is negative, then we can say that it's a TIA. But if their symptoms resolve within 15 minutes, but we do MRI and there is still an infarct there, even though their symptoms have completely resolved within 15 minutes, still it won't be a TIA, it will be a stroke, but because we have radiographic evidence of stroke. So most of the time symptoms resolve within 24 hours, but the main thing here is that there should be no radiographic evidence. If someone has TIA, it increases the risk of future strokes too. So we need to identify and manage all the risk factors. I will go over some of the risk factors in next slides. So there is a score that is available on MedCalc2 ABCD square for TIA. So it includes age, if it's more than 60, score, we give a score of 1. Blood pressure is more than equal to 140/90, then 1 score. If there are clinical features of TIA, then it score could be 1 or 2. Duration of symptoms. So if duration of symptoms is less than 10 minutes, then the score is 0. 10 minutes to 59 minutes, 1 score, and more than 1 hour, 2. And history of diabetes, 1. So if there is a score of less than 4, then we call it low risk TIA. If there is a score of 4 or more, then we call it high risk TIA. And they're at probably more risk of future strokes or TIA. So now we can go over management part. Any questions so far?
Are you gonna go over what the ABCD score changes in your management? In this case, I don't want to steal your thunder.
ABCD score changes.
Yeah, you told them about the score. Now, what would they do with that score? How does that change what they're gonna give the patient?
Yes, I will go over in the management. Yes, I will go over it. So let's assume that there is a 60-year-old patient who presents to emergency department and there is concern for stroke. So what I noticed with my emergency rotation was that whenever EMS picks a patient and there is concern for stroke, they call the emergency department and they let them know that they will be here in 10 minutes. So then they announce in the emergency department stroke alert, estimated time of arrival 10 minutes, 15 minutes. And most of the time, emergency medicine doctor is waiting for the patient. They go there before EMS is there. But sometimes patient is brought by a family member and not by EMS, and then still they try to see those patients as a they can within 5 to 10 minutes. So what do you guys think is the most important thing when we are seeing the patient with suspected stroke in the emergency department? What should we do first when we see them?
Vitals, history.
Yeah,
Vitals,
vital,
blood sugar.
yeah, blood sugar is a good thing. Anything else? What in history?
How long?
Yes, so this is really important. So he mentioned that how long, since when the symptoms started. So first thing is we need to make sure that this is a stroke, because when they come, when EMS picks up patient is sometimes encephalopathic. And because of encephalopathy, patient is not moving extremity and it gives a false impression, oh, someone may have a stroke. So we need to first determine that patient has a stroke, get a good history. Sometimes history taking is really easy. Patient comes, they have weakness, and they can tell you that, oh, his symptoms are at this time. But sometimes patients are encephalopathic. In that case, we get history from EMS, friends, family members, anyone who can give their input, so that we can get an estimate of last well-known time, because this will determine our management if patient has stroke. So I will go over this in the next couple of slides too. So, and then we will roll out seizures, hypoglycemia. These are very common. VOC glucose could be checked in a minute when patient comes while we are doing our physical examination. Then we need to risk stratify stroke with NIH stroke scale. Most of the time it is done by emergency medicine doctor, because they are the one who will be seeing those patients first before take care of the patient. So there are multiple components of this stroke scale. It's available on MedCal too. So it includes whether patient lost consciousness or not, motor symptoms, it has dysarthria, aphasia, whether they lost sensations, facial palsy, or videogram deficits. So, and we give them a score from 0 to 42. More does higher the score, more severe stroke and less chances of recovery. So if someone's score is less than 5, it's minor stroke. If it's 5 to 15, moderate stroke, and more than 15, then we call it severe stroke. So now we know that patient has a stroke. We stratify them. We immediately need to do CT scan, non-contrast CT scan of the head. Why are we doing non-contrast CT scan and not contrast CT scan? And what do we want to see on this non-contrast CT scan? Yes. So the reason of doing non-contrast CT scan is that we want to rule out hemorrhage. That's the first step, because if someone has stroke, we want to quickly rule out that this is not a hemorrhagic stroke, it's a ischemic stroke. So once we did the CT scan, we ruled out hemorrhage. Now the next important thing is we need to assess whether patient is a candidate for thrombolysis or thrombectomy or not. So this is where last well-known time is really important, because for thrombolysis, we can do it within 4.5 hours of disabling symptom onset. And disabling symptom onset is really important. I will go over some indications and contraindications of thrombolysis in the next slides too. And for thrombectomy, therapeutic window is within 24 hours. So what is fibrinolysis? So we use an epiplase here, the TPA. So what it does is it converts plasminogen to plasmin, and then plasmin breaks down fibrin clots. So some of the indications of thrombolysis are, so first we need to make sure that patient has a clinical diagnosis of stroke and they have disabling neurologic deficit. So sometimes patient comes to emergency department, oh, I have sudden onset right-sided weakness and left-sided weakness, and by the time they come to emergency department, their weakness has already significantly improved. So those patients are not a good candidate for thrombolysis. But if someone comes in the emergency department, they are not able to move their arm or legs, or they have severe aphasia or dysarthria, any neurologic deficit that will be disabling in the future, whatever NIHS score is, will give them thrombolysis if there is no contraindication, if they present within 4.5 hours. So some of the absolute contraindications of thrombolysis are if someone has had traumatic brain injury within 14 days, they had neurosurgery within 14 days, spinal cord surgery within 3 months. If they have persistently elevated blood pressure and the cutoff is systolic more than 185 or more and diastolic more than 110 or more. Any active internal bleeding is going on, if we are treating them for infective endocarditis, if they have severe thrombocytopenia and they are using anticoagulation, probably they warfarin or any other anticoagulant, then their INR is 1.7 or more. And if we do a CT scan and we see that there is a hemorrhage there, we can rule out that they don't need thrombolysis. So what are the blood pressure goals? So blood pressure goals are different. So if someone comes with an ischemic stroke and we do thrombolysis, then blood pressure goal is different. If they don't require thrombolysis, then blood pressure goal is different, and for hemorrhagic stroke, it's different. So first, I will go over blood pressure goal if someone is requiring thrombolysis. So before giving them TPA, blood pressure should be less than 185 over 110. After giving them TPA, our goal should be to maintain blood pressure less than 180 or 105. But if we are not going for thrombolysis, like someone does not have these symptoms or they are not a candidate for thrombolysis due to any contraindication, then we'll allow them permissive hypertension because if we quickly reduce blood pressure in these patients, there is a risk of worsening ischemic stroke. For hemorrhagic stroke, blood pressure goal is 140 to 160 systolic. So for hemorrhagic stroke management, all of these patients from emergency department will go to neuroendovascular unit where they will be. So sometimes for hemorrhagic stroke, not everyone requires surgical intervention. So if there is a small hemorrhage, there is no midline shift on CT scan, then sometimes neurosurgery will just monitor them in your ICU. But if there's a large stroke, midline shift is there, patient has severe disabling symptoms, they will just directly take them from emergency to the neurointerventional unit and they will do craniectomy if needed. So for these blood patients, we need to maintain a blood pressure close to 140 to 160. So if needed, we can just use IV the beta load as needed, or we can, if we have to start IV myocarditis, if they are requiring frequent IV the beta load. For other important considerations, there are that some of these patients may require anti-epileptics. So not everyone requires this, but if someone presents with hemorrhagic stroke and they have a seizure, so in those patients we can start it, but not everyone requires it. And same for hypertonic saline or mannitol and steroids. If there is significant edema, then we can use it. But most of the time, it's used by neurosurgery and not by the or intensivist, it's not used by INT.
Have they ever start anti-seizure medication for prophylaxis, just needed for?
So for guidelines, we don't start it, but I have seen a few patients in neuro ICU that neurosurgery sometimes started too. But it depends on the neurosurgery. But what I was reading is that if someone does not have seizure, then we don't need to prophylactically start it. So here's a stroke timeline. So on EMS pre-notification, as I mentioned, that we need to activate code stroke. If there was no pre-notification, then the ED physician should try to see the patient 5 to 10 minutes. And initial CT scan, non-control CT scan of the head should be done within 20 minutes and read within 25 minutes. If patient is a candidate for thrombolysis, then TPA should be given within 45 minutes. So, and after that, if patient is a candidate for thrombectomy, it should be started within 90 minutes. So all of those patients who are a candidate for thrombolysis, if they have large vessel disease and we know that they will be needing needing thrombectomy, we can still give them TPA because guidelines have shown that there is a long-term symptom, long-term benefit if we give them TPA, even if they will need thrombectomy. So after the acute management, there are a few labs that we need to do. Some of these labs could be done, like ECG will be done within a few minutes, but the other labs like CEC, CMP, lipid panel, HbA1c, we don't need to wait for these labs before acute management, but all of these patients need it. So all of these patients need CT angio, guided Dopplers, echocardiogram and MRI brain within 24 to 72 hours. So after this acute management of the stroke, we need to do secondary prevention. So for that, we use dual antiplatelet therapy, anticoagulation, or statins. So all of these patients should be on statin if there is no contraindication. And then according to the mode of what caused the stroke, I will start them on anticoagulation or antiplatelet therapy if there is no contraindication. So for antiplatelet therapy, so patient presents with acute stroke. If they are eligible for thrombolysis or thrombectomy, we will do that. After thrombolysis or thrombectomy, we need to wait for at least 24 hours before starting antithrombotic therapy. But if patient is not a candidate for thrombolysis, then we can start aspirin and Plavix as soon as we can if there is no contraindication. So so here up to date says that if someone has minor stroke that is NIH score of 5 or less, then we can start them on dual platelet and antiplatelet therapy. But if the score is more than 5, then if someone has moderate or severe ischemic stroke, then we can start them on aspirin alone. I was reading the AHA guidelines. AHA guidelines are only for high risk TIA and low risk stroke. There are no guidelines for major stroke, so they mentioned that we need more studies. So it depends on the neurology and neurosurgery. In our hospital and during my neurology rotation, what I noticed was that all of the patients with TIA, whether they had low risk TIA or high risk TIA, neurologists prescribed them aspirin and Plavix for 21 days, and then aspirin monotherapy after that. And for stroke, whether it was minor stroke, major stroke, if they were a candidate for dual antiplatelet therapy, they were starting on aspirin and Plavix for 90 days, and then after 90 days, just aspirin monotherapy. So here's a slide for TIA, but it's the same. So here up to date is the same, that if score is less than 4, we can start them on aspirin. And for high risk TIA score is 4 or more, then we need to start them on dual antiplatelet therapy. But during my neurology rotation and when I spoke to neurologists, they just recommended that they start everyone on dual antiplatelet therapy. 21 days of Plavix won't hurt anyone if there is no contraindication. So they just prefer in our hospital that everyone should get for 21 days. And after that, just aspirin monotherapy for TIA. So all of these patients need modification of risk factors. So we see a lot that most of these patients who present with stroke, atherosclerotic stroke, they have hypertension, severe dyslipidemia, diabetes, smoking, physical inactivity, OSA, alcohol and substance abuse disorder. So we need to manage all of these too. All of these obviously cannot be managed during the hospitalization. So it depends on the patient too, that they need to follow with their PCP so that over time we can manage all of these modifiable risk factors too. All of these patients require multidisciplinary care. So if someone has a ischemic stroke or hemorrhagic stroke, they're in ICU, and the hospitalist team is following them. Neurosurgery, neurology, ICU team is following them. This person needs modified diets. So SLP is following them, speech language pathologists. They need physical therapy, occupational therapy, so they're following them. And case manager has a very important role too. So for SLP, for modified diet, PTOT for rehabilitation. So for case manager plays a very important role here too, because most of these patients on discharge require some medical input equipment, wheelchair, shower chair, walker. They need skilled nursing facility placement, inpatient rehab placement, home health care. And it gets challenging when they don't have insurance. Sometimes see a patient that will present with stroke, they have severe disabling symptoms, and they don't have insurance. And they stay here for weeks because case manager works on getting charity. Sometimes we're able to find inpatient rehab placement or skilled nursing facility on charity. Sometimes we're not able to. So in that case, they try to get home health care on charity so that PDOT can go and see them at home. Something is better than nothing. So, and after the acute management on discharge, they will be going to sometimes to long-term acute care hospital without that, but mostly they go to either skilled nursing facility or inpatient rehab. But if we notice significant improvement during hospitalization, then they can go to home with home health care too, so that TTOT can just see them at home. So now some order sets. So stroke, there are 3 order sets for stroke. One is if someone presents with ischemic stroke and they are not requiring thrombolysis, and probably this order set is probably the most that we will be using. Because if they are not requiring thrombolysis, that means that their symptoms are not disabling. Unless if there was some indication for thrombolysis, then these patients probably can go to. So medicine team will be the primary team that will be following them. So we need to place this order set. But after receiving thrombolysis, or if someone has cerebral, if someone has hemorrhagic stroke, those patients will go to neuro ICU. So this is an order set. You can see that ischemic stroke without thrombolysis admission. So an important part here is that first of all, these patients should be NPO before speech language pathology is out. So all of these patients should be NPO. Then you can see that there are vital signs instructions that these are nursing instructions that they need to maintain blood pressure, check blood pressure every 1 hour, 2 hours, and notify the provider if systolic blood pressure is more than 220 or diastolic more than 120. Then there are continuous every 2 hours neuro checks. So all of these patients should be on telemetry, and telemetry is a part of stroke protocol too. As we can mention that there are some indications for telemetry, and for acute stroke, they should be on telemetry for at least 48 hours. But if they're going to ICU, then we can select patients with indication for ICU, and they will be on continuous telemetry while they are in the ICU. So telemetry is a part of order set. And then there are more nursing instructions. So nurses can do bedside swallowing well. They will have on every shift, they will examine the patient and just to make sure that patient does not have any new deficits.
Patient telemetry monitoring and putting in 24 hours.
So you're saying 48 hours or 24 hours?
So the first one, is the first one 48 hours?
First one is 24 hours, next one is 48 hours, and then we can do continuous telemetry too. So
So what, that one?
And then we put the 24 hours.
Then, so it depends, So for stroke, you can see that these are all the recommended telemetry durations. For acute stroke, it's 48 hours. But if they are going to ICU, all of those patients are on continuous telemetry. So those patients will be on continuous telemetry. But if this patient is going to PCU, then we can just select 48 hours. So all of these patients need PT, OT, SLP, eval, so these are part of the order sets too. We can separately place these orders too, but it's easy to place through order set while we are just admitting the patient. So next thing is that these patients need lipid panel and then for DVD prophylaxis. So don't start these patients on DVD prophylaxis on admission. First consult the neurologist. Sometimes they are okay with it. If we're not doing thrombolysis, sometimes they're like, wait for 24 hours and then start it. So for ischemic stroke, for hemorrhagic stroke, obviously it's hemorrhage, so we won't start them on DVD prophylaxis. Can you go down? So, and then we'll start them on aspirin and Plavix and with the atorvastatin as soon as we can if we are not doing thrombolysis.
Is a neurologist a part initial team who admit the patient in ED or with neurologist going to?
So neurology will probably see the patient before we are admitting them. So, but they would. So first patient comes from emergency department, pediatrician will see them. So sometimes this patient is just encephalopathic, there is no stroke. So they will first see and will confirm that patient has stroke. If the patient has stroke, then they will immediately call the neurologist, and neurologist immediately come to the emergency department to see the patient. So most of the time, neurologists see the patient before us, before we admit the patient. And then while we're admitting the patient, I think patient has already received thrombolysis most of the time. So then there is a stroke order set post IV thrombolytic admission. And we can see here that so most of the order set is same. So I just added a couple of slides that are different. So this order set includes some bleeding precautions. There is an automatic note here too that not antithrombotic therapy for 24 hours after IV thrombolytic stroke, and do not give anticoagulant, antiplatelet, or NSAID medications. So these will be the nursing instructions. So and then for vital signs, for ischemic stroke without thrombolysis, we were checking vitals every couple of hours. But here you can see that it's every 15 minutes for 2 hours, then every 30 minutes for 6 hours, and then every 1 hour. So these will be done by nursing staff. So we need to place this order so that they have it and they can follow it. So all of these other steps, pulse oximetry, telemetry monitoring is the same. The only other difference here is the systolic blood pressure. I think it's also the same that we need to make. So for without thrombolysis, nursing instructions were maintain blood pressure less than maintain blood pressure till 220 or 120. So if blood pressure is more than 220 or 120, they will let us know. But after thrombolysis, the blood pressure goes is different. We need to maintain blood pressure less than 180 systolic and less than 105 diastolic. So this is one of the difference. And another difference is that
First 24 hours, this blood pressure.
yes, 24 to 48 hours. So then the other difference is that all of these patients will need a repeat CT head, non-contrast CT head after 24 hours. Because I don't know why we are increasing a non-contrast CT head in these patients. Yes. So he mentioned that to rule out hemorrhagic conversion. So because we are giving them TPA, there is a chance that ischemic stroke will convert to hemorrhagic stroke. So that's why we need to do repeat CT head. If it's negative, then we don't need to repeat it. But if we see that there is some hemorrhagic conversion, then for neurology, neurosurgery, we need to repeat it more frequently to make sure that the hemorrhagic conversion is not progressive.
What's the chance of hemorrhagic conversion? What if a family asks? That's pretty close. I don't know who said that. It's like 5 to 7%. Yeah. And then what's the chance of it being fatal? It's like 2 to 3%.
What?
Thank you.
2 to 3% chance of fatal.
2 to 3% of all those who develop the
All the
American
plays.
or
Oh, of the patients that develop the intracerebral hemorrhage.
so yeah, so out
2%.
of all 6% patients who develop hemorrhagic conversion, out of these 2 to 3% have fatal.
Yeah, it's not normally deadly, but it can be.
Another difference here is VD prophylaxis. So for if patient is not requiring thrombolysis, then we can start them on heparin or Lovinox after confirming the neurology, and most of the time they're okay with starting within 24 hours. But if we are doing thrombolysis, then we need to wait and confirm with neurologists. Most of the time, if there is no hemorrhagic conversion, I think we start it here after 48, 72 hours. They're okay with receiving it too. And if needed, this is the part of RSI2 that IV labetalol should be there as needed to maintain blood pressure less than 180 or 105. And if we are needing labetalol more frequently, we can start them on nitardigine 2 to maintain low blood pressure. So then there is another set for intracerebral hemorrhage. So most of the time, all the patients with cerebral hemorrhage from ED will go to neuro ICU, and intensivist will be the one who will be placing disorder. So as usual, this patient will be on NPO. Patient will be NPO. Then vital monitoring is different for this one too. It's every 1 hour, but for first 12 hours, every 1 hour, and then every 2 hours. Then another difference is that mechanical DVD prophylaxis is absolutely contraindicated in these patients because of hemorrhage. So we will just do SCDs in these patients. And then anticonvulsants are also a part of order set, but not every patient needs it. We are suspecting. So it depends on neurology, neurosurgery. Do I've seen that they have started Keppra on a few patients just for prophylaxis. I had a patient, she was 92 years old, and they started her. So she was presenting with frequent fall. The one fall she presented and she had epidural hematoma. Next time she presented, she had subdural hematoma. So neurosurgery just started her on Keppra for prophylaxis purposes. But most of the time, we just started if someone has seizures. So any questions so far?
So in real life, how to differentiate between ischemic stroke and TIA?
So when patient comes in the emergency department, there is no way that if symptoms have not resolved, then we cannot tell whether someone has TIA or someone has stroke. So because we will do CT scan on the head, it will be negative. But if patient has disabling symptoms, we'll still give them TPA. Even if it's a TIA, because we cannot tell whether it is a TIA or stroke. If their symptoms resolve within 24 hours, we do MRI of the brain next day and it's fine, and we'll say that it was TIA, but they will still get it. There is no way that we can tell them if the symptoms have not resolved. But we will give them TPA if they have disabling symptoms.
I have one question.
Yeah.
So most of these people who have developed stroke have multiple risk factors for cardiovascular diseases. So suppose if patient is admitted for ischemic stroke, and during the admission, or maybe hemorrhagic stroke, during the admission he develops acute coronary syndrome. So this is the dilemma, like that requires anticoagulation, antiplatelet, but that puts contraindication in that therapy because of the
Well, if they develop this, then yes, then cardiology, neurology,
Yeah, they're
something like shared decision making, whether we'll see
That's a
whether
consult palliative care.
yeah.
what's the benefit, whether there is a benefit of anticoagulation or they require palliative consult, so it depends. But so it will be shared decision making then that
They will be fighting.
I don't think I've ever seen that.
I think there was
Yeah,
one
can you
patient
do
that
that?
did thrombectomy, sometime they do. I had a patient, that patient came with acute limb ischemia. So he had a thrombosis. On top of that, he developed a stroke, basal artery. On top of that, during the same admission, within a span of couple of days, he also developed STEMI as well. So they tried thrombectomy, but the stroke, I think, was already too progressive and involving the brainstem. But they didn't do the TPA because it was like clearly contraindicated.
Because all the diseases have a shared risk factors.
Yes.
So risk factor for one disease increases the risk for another.
Any other question? So some take-home points. So history and clinical examination, as usual, is really important because first step is to determine whether patient has a stroke or not. Once we have determined that patient has a stroke, then the next step is to quickly do CT scan of the head to rule out hemorrhagic stroke. Once we have ruled out hemorrhagic stroke, then we need to assess whether patient is eligible for thrombolysis or not. So we need to make sure that we know the last well-known time. And then we need to rule out all the absolute contraindications. If someone has some relative contraindications, so in those cases, we'll say well, if there is more benefit of thrombolysis or not. After acute management, all of these patients should be on dual antiplatelet therapy or anticoagulation as per the reason of the stroke and statins if there is no contraindication. All of these patients, we should try to modify all the risk factors, as I mentioned, hypertension, diabetes, dyslipidemia. We should try to modify those factors, and all of these patients require multidisciplinary care. So a good communication between teams is really important. So, thank you. Any questions?
If you have a patient with a stroke, he doesn't have any obvious symptoms of dysphagia or dysarthria. We still keep him NPO and did not allow even oral medication. Still, he's seen by therapy, or we have some options for this.
So yeah, if someone does not have dysphagia or dysarthria, they are aware, because we see a lot of these patients too that they're telling us all the history. In that case, we can just do bedside swallow. So their bedside nurse can do swallow eval, and if they pass, we can just resume it. So, but SLP eval is for those patients who have dysphagia or dysarthria or aphasia. But regardless, we can still resume diet after bedside swallow, but SLP can still see them. There's no harm in that, but in these patients, you can stop them.
We'll try to get the worst stroke center, right? Still certified stroke center.
Yes.
We'll try to get the stroke coordinator to come talk to you guys once you're settled in and experts in a couple of weeks. Because there's a lot of little things we have to do here to maintain our status as a certified stroke center. So it'd be cool if they could come talk to you about what we have available. And I think there's some visual subtraction angiography and ways to check for penumbra and all that before we
That's
get
done by
dialysis.
radiology.
Yeah, so there's a lot of things that are changing almost like weekly, monthly. So we'll keep you updated as the year goes on.
And it's very important to follow the rules of their guidelines, what they have.
Yeah.
Because of even if you think, perhaps in this patient, is it really necessary? You
Still,
order it because there's a certain way of doing it to keep the stroke
accreditation.
stratification and
Like, let's say you have to send them home without a statin because their ALT is through the roof. You need to document the heck out of that, or else they'll come back at us 3 days later. Why did you discharge this stroke patient without a statin? We're going to lose our certification. And so they're really stingy about it, but it's important.
I just wanted to make one comment. All of you guys got access to AMBOSS, correct? So on AMBOSS, while you were going through that, because we have access as well. When you're on call or on the floors, if you haven't already figured it out, go to your on-call survival guide under your library. So back in the days, we all carried around a little black pocket medicine book from Mass General. And that's what had all of our tidbits and secrets in there. This one has an on-call survival guide. And I followed your lecture with ischemic stroke, and it lists everything. So if you're on call, quick reference, it references, links everything, has all your calculators. One place, all you need is AMBOSS. It goes, the calculators, everything.
And I believe
So
we
that's
have an
good.
introduction to AMBOSS on
This week, Friday.
Friday?
Yes.
Friday, so somebody will tell you how to use it most efficiently. And we really want you to use it because we have on top of it a bit of a trial with Ambos on. It's such a good app as we believe it might be thinking, as we believe it is. Okay, thank you. Thank you so much.